Voila, welcome to this community talk, the last one of 2023. In this community talks, we will discuss the research on building primary healthcare in Sub-Saharan Africa. And we will look at what this project has already realized so far and what is planned for the future. We would like to give the floor to Professor Jan de Mazeneer and PhD researcher Bianca Silva. Before starting, two practical announcements. Throughout the presentation, you can already raise your questions in the chat, and then we'll discuss them after the presentation during the Q&A. And a second announcement is that this community talks is being recorded so that we can share it afterwards on our YouTube channel. Voila, without further ado, let's dig in. We hope you enjoy these community talks.
Good morning, everybody. It's an honor for us to share the story of the Primafamed network, and we will do that with myself. I was the former coordinator of the network, with the coordinator in Belgium, which is Bianca da Silva actually, and also with the actual international coordinator in Africa, Professor Bob Mash, who will join us with his video contribution. The title is Looking Back at the Future. It's important to look back when you started something in the late 90s and to see what difference you have made. And we'll try to shed some light on that. Next slide, please. First of all, I want to remind you that we work actually in the framework of a WHO collaborating center. Maybe you're not familiar with that, but WHO has multiple collaborating centers on different topics. And primary care and family medicine is one of those. In the world, there are only 10 collaborating centers working on family medicine and primary healthcare. Ghent University is one of those. So we work here with a multidisciplinary team working on research, education, and policy. And actually, Bianca is coordinating this center. Next slide, please. Let me start this with a personal story. I think, as for many people, the confrontation with the African reality was also for me a life-changing experience. So in 1977, I had the opportunity to work as a medical doctor in Rwanda, and I could work there as a family physician in a community health center in Gisagara. We were responsible for more or less 40,000 people. Every morning, there were 400 people queuing. And we had a kind of strategical approach to address the needs of all of them. And that was a very broad scope. You see here also our activities in deliveries. And we really had a wonderful team with nurses, midwives, community workers, health educators, and so on. And the most important thing from this experience was, first of all, that I was forever infected by the Africa virus. But the other was that we learned a lot from this experience in Gisagara to start primary healthcare in Belgium. And next slide. It was inspired by the African experience that in 1978 we started a community health center in the Botermark in Ledenberg, where family physicians, nurses, dietitians, health promoters, dentists, oral hygienists, social workers, psychologists, and community health workers still nowadays work together, taking care actually for 6,200 patients coming from 95 different countries, a lot of them coming from Africa. And where we have established an integrated primary care system with integrated capitation. And what we also learned from Africa was the community-oriented primary care strategy that we have implemented ever since. So my first lesson is you can learn a lot from Africa. It's a reciprocal process. It's not us that bring the knowledge and the wisdom there. It's a shared learning process. Later on, next slide, please, started to be the chair of the Department of Family Medicine, Primary Healthcare at Ghent University. Since 1991, I was appointed in that function. And in 1995, I was looking for an international cooperation. I came in contact with Professor Dumo Bakwa, who was the newly appointed professor in primary care at UCT, University of Cape Town in Africa. The meeting was organized by an NGO, fundraising NGO, and was a very strange meeting. It took place in the Royal Automobile Club in London only for men on the 5th of October 1995. And there was such a contradiction between the setting, very aristocratic, and our interaction, Dumo and myself, because after 10 minutes we thought we know each other for a very long period of time. He has been active in the ANC, represented ANC also in Europe. I have been very active also in the anti-apartheid movement and the support for the liberation movements in Southern Africa in the 70s. So there was a lot of understanding, and Professor Bako invited us to make a study visit to South Africa because, as he said it, you need to see the cold face of primary care before you will understand what is possible to do and to cooperate. Next slide. So that visit took place. I had the opportunity to visit the 7 departments, all starting departments in South Africa in those days. And then we decided to bring the 4 departments in Flanders together with the 7 departments in Africa, and that was in Durban. And in 1997, what happened there was what we still call the Durban miracle, because with the 11 departments there was such an understanding, such a shared feeling of we are in the same track, we are fighting the same fight. And so that really brought a momentum. And it was decided there to start the Family Medicine Education Consortium in order to give a structure to cooperation, as we had already in Flanders, to the training of family doctors in South Africa. And this cooperation was very intensive with sharing curricula and training complexes between universities. And it was also the start of the South-South-North cooperation that is further developed ever since. It was, of course, very important to try to find ways of financing, because an initiative is nice, but you need money. And so what happened was that we looked for funding through the Vlier Own Initiatives programs, but that was not a very easy enterprise. We made a proposal focusing on capacity building. And when I was at the interview to discuss the proposal, the first question was, how many PhDs are you going to deliver in the forthcoming 3 years? My honest answer was probably none. And it was also difficult to explain the concept of South-South cooperation to the jury, because we said we are not going to teach there. The knowledge is in Africa, but we are going to try to work together to facilitate and to kind of networking in order to make a change happen. But after 2 attempts that failed, we finally were successful, and we got the funding with the 2003 project that was then focusing on South Africa. But immediately we had questions from other regions in the SADC region. And so we decided to give a follow-up to this first project by involving other Southern and Eastern institutions. So finally, we ended up with almost 20 departments of family medicine in 10 different countries in Southern and in Eastern Africa. So that was for us a very important moment, because then we became part not of a bilateral, but of a global kind of network in South Africa. In those days, you see here some training complexes. One is in Makerere in Uganda, the other is in Tanzania, and the last one is also in Kenya somewhere. So that was the way we developed training. We supported training, and we learned from each other how to better be responsive to the needs of the population. So that was more or less the process that we went through. Next slide, please. The highlight in those days was the conference in 2008 in Kampala. The conference brought African partners together, but also other international agents that were active in Southern Africa. There were more than 100 participants. It was a very vivid interaction, and we focused there on building strategies together for curriculum development, sharing resources, exchanging external examiners, start of research also with them, the first PhD projects that were put on the line for further development of research. Also, we shared a lot of experiences in advocacy because both in Belgium and in Africa, it was important to put a lot of advocacy to strengthen primary care, and that was also one of our actions. We worked together with Ghent University, but also with the other universities in Flanders that were also involved. Next slide. At the same moment, thanks to a VLIR grant, and we used 12,000 euros for this project, we could start with a journal, the African Journal for Primary Healthcare and Family Medicine. I think it was the best investment we ever made in my career, because nowadays it's a completely self-supporting leading journal in Africa. Over 100 new articles are published yearly, and this was really the start for giving a platform for science and for research to the African community in primary care. We started also some PhD projects like the one on the emergence of family medicine in Africa that finalized in the PhD defense at Ghent University. Next slide. In 2009, we changed the strategy with the twinning project. So we then asked departments of family medicine in South Africa that were already strongly developing to twin with programs in other regions, sometimes regions without a medical faculty, or even regions without a university like Lesotho and Eswatini. This kind of links still works, and this kind of bilateral cooperation is a very strong strategy to make a network strong. Next slide, please. Of course, it was time for evaluation. Did we make a difference? And actually, you can see if you go to the website of the African Journal that there are over 100 publications of where Primafamed network is involved. Primafamed, by the way, is primary care, family medicine, education. And one of the studies we did by Michael Flinkvleugel was to see, did we make a difference in the period 2008-2010? So what we did was we defined 4 levels of development of capacity building. The first is the structural implementation of a training program is in preparation. Then the second level was it exists, and there is training complexes are under development, and the family medicine is also part of undergraduate training, not only postgraduate training. Level 3 was the curriculum is written, the postgraduate training has started, and level 4 was the department exists and the Ministry of Health has accepted family medicine as a specialization, and graduated family physicians are part of the healthcare system. So we looked at those 4 levels, and then we looked at a sample of 10 of the universities that were involved in Primafamed. Next slide. And as you can see, for instance, for Moi University in Kenya, in the 2 years, they were leveling up from level 3 to level 4. Aga Khan University, Tanzania, evolved from level 2 to level 3. The University of Lagos went from level 1 to level 2. Harare University from 2 to 3. Gezira from level 1 to even level 4. In Sudan, unfortunately, later on politics made that this project could not further develop. But we could really see that we could make progress, and that was for us very inspiring. Of course, we could not work for family medicine only. We would like to frame this in the broader context of human resources for African primary care. Next slide. So we were very happy that Primafamed was granted with a full 4.5 million grant from the EU FP7 program, where we looked at the different situations when it comes to doctors, nurses, and midwives in Africa. Next click, please. And the research objectives of that process were assess the scope of the deficit in human resources in Africa with a focus on primary healthcare, identify and analyze the main causes of this deficit, develop, review, and test possible interventions, and finally formulate scientifically sound, acceptable, and feasible policy directions for the future. And that was not only a scientific exercise. I still remember at a certain moment in time that from the project we intervened in a parliamentary discussion in Kampala because the government wanted to cut the health budget. And with the evidence from the project, we could contact all the MPs in Kampala. And finally, this proposal of the government was not accepted by the parliament. So it was not only doing science, not only capacity building, it was also strengthening political pressure in order to strengthen the development of primary care. The next slide, ladies and gentlemen, is the most dramatic slide and graph of my career. what do you see here? The distribution of the graduates in the Faculty of Medicine, 790, at the Harare University of Science and Technology. We did this analysis in the framework of the EuraPrim project, and what we saw was that 88% of the graduates were still active. It was a period of 10 years, more or less, were still active in Uganda, which was, of course, a great result. But what was the problem? 51% of the graduates were working for one single disease, mostly not in the public health system, but for an NGO. And for me, that's a dramatic graph, because what it illustrates is that all the efforts in capacity building finally went to people that merely had administrative functions in order in big NGOs, and that this really did not make a difference for the development of primary care. So that was one of the striking moments that we were confronted with a huge problem in Africa when it comes to organization of healthcare. Next slide. And that is that there is this intensive verticalization, originally for infectious diseases like malaria, tuberculosis, AIDS, but nowadays also for the so-called chronic conditions or NCDs. And this verticalization is absolutely leading to fragmentation of care and to inequity by disease, certainly also because multimorbidity is more and more also the case in Africa. Next slide. And sometimes when I'm critical, I say Africa died twice from AIDS, the first time because the patients died, the second time because the health systems were largely destroyed through this vertical disease-oriented approaches, also leading to inequity by disease when educational grants and food grants became part of the package of people that were confronted with that disease. And of course, we learned a lot from these vertical programs, but it was destructive, I think, for the health systems. And we were strongly confronted by that, by this development. And that's why we started already early years ago a campaign, next slide, please, what we call the 30 by 2030 campaign, where we call for major international donors to sign a part of their vertical disease-oriented categorical budgets, increasing to 30% by 2030, to strengthening horizontal primary healthcare systems so that all diseases can be prevented and people treated in a comprehensive way. This puts into practice the resolution of WHO to encourage that vertical programs, including disease-specific programs, are developed, integrated, and implemented in the context of integrated PHC. Next slide. And if you want to support this, please go to the website and sign the petition. We aim at having 1,000 signatures as soon as possible. Next slide, please. And you see it's supported actually from all over the world. Next slide. In 2019, we decided all together that the Primafamed network would become an African organization. So the Africanization of Primafamed took place. At the same time, we started also with an international thematic network on climate change, migration, and health, the climate health. And we had the opportunity that our first data collection in the framework of that network could take place in Africa. So the first publication we made in the framework of this nexus between climate change, migration, health was based on qualitative research with family doctors from Africa that indicated what impact these dimensions have on their situation in their communities, where they try to make primary health care responsive to the changing conditions, the changing epidemiology, the changing health care structure, because all these elements were affected and are affected by climate change. Next slide. This ITN is still ongoing. And then, my final question, because nowadays the network is self-supporting, but what we see is that it's so difficult to find financing for ongoing network. This network exists actually since 1997. It's still growing. You see it is actually active with over 40 institutions in 25 African countries, also in French-speaking countries. And every year it's a fight to try to find this 50,000 euros that we need as the basic funding to make this network happen. And it's nor possible to finance this through projects, although we are very grateful that thanks to Norwegian aid, we have now the money for the next 2 years, but this is not a sustainable way. So my plea to Vlir is look for a mechanism to finance this kind of networks so that there is a continuity on which the Africans themselves now build a lot of research projects that they find grants for themselves. But that's absolutely essential to make it sustainable. Next slide. That's the final slide. In Africa, people say there is a black man in a white skin, but that white man learned so much and is so grateful for all the richness of the experiences and the friendship that I've received in all those years and still today in Africa. I give you now the word to Professor Bob Marsh, who is the actual coordinator from Stellenbosch University, the head of the Department of Family Medicine, and also the editor-in-chief of the African Journal for Family Medicine and Primary Healthcare. We listen to a short intervention and then Bianca will continue.
Hello, everybody. My name is Bob Mash. I'm the coordinator of the Primafamed network based in Cape Town, South Africa, at Stellenbosch University. This is my second video. My previous one was about 7 minutes, so I'm trying to produce a shorter version of the same thing. So I'll make my points quickly. So what has enabled the development and sustainability of the Primafamed network? So I think, well, first and foremost, I don't think the network would exist without the initial strong vision and sort of persistent incremental support from Jan de Mason here. So I think he's been instrumental in the initial development of the network. And of course, the support from Vlir itself, much of which he was able to obtain for us from Belgium. Having said that, I think one of the other key points is that the network from very early on emphasized that this should be South-South collaboration with support from the North and not just North-South, as exemplified by the twinning project we did between South Africa and many other countries. The face-to-face meetings that have been funded over the years have also been really important in developing relationships, getting to know people, feeling like you are in a very small, often department in your own institutional country, but you're part of a bigger whole. And I think that's been very important as well. People have appreciated the opportunities for collaborative research between institutions, between countries, through initiatives like the Hurriprim project on human resources for health, or more recently, the Primary Healthcare Research Collaboration, or the Climate Change, Migration and Health Network. The other thing, though, I think is that although Jan, I think, is very important in the early days, I think it's also good that the leadership of the network has moved away from Ghent, from Belgium, and is now solidly in the hands of Africans. So although I'm coordinating the network, there are 3 directors based in East, West and Southern Africa, and a board of directors from the different countries. There's about 25 countries in the network from Sub-Saharan Africa. So the other key things I think that have been important is the launch of the journal, the African Journal of Primary Healthcare and Family Medicine, which I think Vlir also supported. And that journal over the last 10 to 15 years has grown and become a really strong regional journal with a developmental philosophy. And in that process, we've been recognized as the academic wing for the World Organization of Family Doctors in Africa. So we've sort of, rather than being in competition, we have got a collaborative relationship with WONCA. And we've also a strong focus on capacity building in the network, which I think has been important, both for educational competencies and for research competencies, through our sort of e-workshop series and through initiatives like the AFRI1 Research Collaboration, which is an online training and mentorship program for novice researchers that was initiated by the sort of the young doctors movement in Africa. So those, I think, are some of the key points, very briefly. we do have a vision for the future. We're looking to try and develop the East, Central and Southern African College of Family Physicians. We're looking to expand the offering of the AFRI1 research collaboration. We're looking to develop training of clinical trainers in the workplace throughout the region. We're looking towards more collaborative research projects through hopefully the primary healthcare research collaboration and through the climate change, migration and health network and others, such as the PRICE project, which is working in Malawi and Zambia. So hopefully that's a bit shorter, and yeah, enjoy the rest of your meeting. Okay, bye-bye.
Okay, so thank you, everyone. And thank you, Professor Damasne, for this historical overview of the collaboration we've been having. And now in my coming slides, I'm going to talk a little bit about what's going on in the moment and our vision for the future of this collaboration. So,
encore un petit enfant, un petit garçon de 3 ans, et je t'invite à faire dire bonjour à la famille ici. Oui. Vraiment, tous. In Nederlands, Nederlands, Frans en Engels. Les trois.
Sorry for the interruption. Please continue.
sorry. Yes. So we have a short initiative project funded from VIR for the development of African WHO collaborating centers on family medicine and primary care. So we are at Ghent University, one of those WHO collaborating centers, like Professor Damasne mentioned. There are only 13 WHO CCs on family medicine and primary care globally, 4 in Europe, 5 in Asia, 4 in North America, and 0 in Africa, also 0 in Latin America. So lots of regions in the world are not contemplating with these collaborating centers. And what the collaborating centers do is they offer academic knowledge, they offer a collaboration for an evidence base for WHO. So there is actually an important political role that these collaborating centers have, because they not only bring the title of collaborating center brings prestige for that research unit, strengthen PHC locally, but also it raises the level of influence from that region on the WHO documents and policies. So our goal with this is to actually develop collaborating centers in the African region and raise the level of influence of those African partners globally. So we developed this joint program with Ghent University and Stellenbosch University being the two promoters, the two partner promoters for the project, based on the pillars of research, education, and networking. And we were still going to pick other 2 African universities to be the candidates to become collaborating centers. To become a collaborating center with WHO, you have to have a history of at least 2 years collaborating with WHO, working together with WHO. And that's what we wanted to have for the duration of the project, to enable the collaboration to start. And then by the end of the 2 years, we could have maybe the title granted to 1 or more of the partner universities selected. So after a process of selection that we did within the Primafamed network, we selected Benin, South Africa, and Uganda as the countries that we would be working with, each of them with their academic institution that would get the title of collaborating center. And we started bridging contact with WHO. So we had, meetings with the WHO Geneva office. We searched for connections also with WHO Afro, and we actually got to meet with them, hear from them what are their research needs, what are their collaboration needs. And then we narrowed down our focus in the research to be about primary care evaluation. WHO has just released a whole manual of a framework for indicators, operational indicators to evaluate primary care. So our goal would be to further develop these indicators and to actually apply some evaluation tools in the context of Sub-Saharan Africa. And yeah, for that, we chose the primary care assessment tool, which is a tool that's already been tested in many countries in the world. And it evaluates the core primary care functions, which are first contact care accessibility, continuity, comprehensiveness, coordination, and people-centeredness. These here in the pictures are our partners. So Anagala, who is the Ghent University promoter, Professor Bob Mesh, who you just saw in the video, is the Stellenbosch University promoter. And then we have Innocent Bezige and Akanki Kefi, who are the partners from both Uganda and Benin. And they are all very motivated, committed researchers who are working now in adapting the primary care assessment tool to the Sub-Saharan Africa context. So in the Primafamed meeting this year, they all presented the tool to the group of experts that were meeting there and started already getting feedback on the several dimensions of the tool, how they should be adapted to the African context. Then we started a Delphi process formally to get these feedback integrated within the tool. And right now we are almost finished with the evaluation of the feedback. And then we're going to start piloting this tool in certain districts, both South Africa, Uganda, and Benin. And then we will have our first results about assessing primary care officially with this tool. And that's kind of the end goal for our current research. Yeah, I think it's a very exciting project that we have with the African partners. And it is also quite ambitious to adapt this tool for the entire region. So we are looking forward to having interesting results come from these pilots. Thank you very much for watching our presentation. Please check the websites of Primafamed, sign the petition of 30 by 2030. Here is also the website for the African Journal of Family Medicine and Primary Care. And we welcome your questions now.
First of all, thank you both for this really interesting presentation. I think it's an understatement to say you achieved a lot, and in the presentation you broadcasted both the achievements, like the remarkable and strong progress made by the Primafamed partners, but you were also critical and had profound analysis on shortcomings due to circumstances or broader contexts. So yeah, we would like to open the floor. So if anyone has a question, don't hesitate to unmute, maybe to open your camera to ask the questions directly to the researchers. In the chat, I see there was already one question of a researcher of the University of Kisangani, Mr. Eric Gandhi. He's asking, how were you able to integrate the social dimension into the construction of primary health in Sub-Saharan Africa? Because in Africa, there is a problem of beliefs, which is why I think we have to insist on this aspect, particularly by integrating women. So do you have any thoughts on that or any comments on that?
Yes, thanks for the question, which is very relevant. And once more is my answer. We learned how to integrate social factors in the primary care. We learned that from the Africans, because in the 40s, it was Sidney and Emily Clark in the Polela region. This was still in the apartheid times, that for the first time in their practice as family physicians, they looked at their population. They looked at the social determinants. They looked at the environmental determinants, and they made a connection between what they saw in their consultations, the practice of every day taking care for patients, and the situation in the community. And they involved the community in making a kind of community diagnosis that, of course, made very clear the importance of social factors. And we later on, this approach was distributed all over the place. The United States took it over. We have it in Belgium. There's many countries, because it is the strategy to look at social determinants of health. Another thing which is true is there is not yet the social care kind of institution in Africa and most countries. So therefore, I think the interprofessional cooperation is important, but there is a very other strong factor, and that also we learned from Africa, that is the community health workers. When you go to Chaiwelo in Gauteng, or you go to primary care practices in Kenya or in other regions, there are people from the community that are shortly trained and that not only bring in medical and health-related information, but also social determinants, because when they visit the people in the community, they're mostly responsible for something like 100, 200 families that they are in touch with. They also look at the social determinants. They look at housing conditions. And that helps, of course, to make a kind of diagnosis of the upstream causes of ill health. So for me, there's a lot of opportunity. There is absolutely this perspective of looking at the social determinants of health, but of course, it needs attention, and there are actually not that many institutes that already train people for social work and social care, but family medicine has a very close relationship with them, because what we see in our daily consultations when we try to work with the patients and with the people in the community is that you have to address the upstream causes and the social determinants. And for example, what we saw in certain regions in Africa, for example, in Nigeria, that when COVID came, that was very well handled, because they have a long tradition with community health workers that are going to visit and are responsible for the families in order to look at contact tracing and, of course, looking at the sources, the distribution of the infection. And that's why in some regions in Africa, there was a much better control than, for instance, in Europe in the first weeks of the pandemic, because in Nigeria, they have it every year, this kind of challenge with one or another infection. So they were very much better prepared. Once more, it's a reciprocal learning. We learn a lot from what our African friends are doing on a daily basis.
Thank you very much. I don't know, Mr. Erik, if that fully answers your question. If not, don't hesitate to unmute and ask an additional questions. But also for the other ones, if there is a question, raise your hand, unmute yourself, and ask a question directly to the researcher. Another question in the chat is from Katharina Derde. Her question is family medicine integrated in African medical curricula nowadays?
The answer is the process is ongoing, and Primafamed contributed a lot to that. There were countries when we started, there was only a postgraduate training program from 2 or 3 years, something like that. What we actually see, and we emphasized always the integration of family medicine. And I remember some years ago, the poster presentation at the meeting in Nairobi of Primafamed, and there were 15 presentations from different countries in how family medicine as a discipline was integrated from the very beginning in the programs. And most of the actual professors in family medicine have absolutely a lot of influence in the undergraduate program. Because, of course, if you have no exposure and experience in primary care during your undergraduate training, you will not choose for a career in family medicine because you don't know it. So it's so important. And the other thing is that, as in all continents in the world, family medicine is one of the disciplines that contributes to fundamental curriculum reform. And I think that was also the case at Ghent University. where Professor Derde and myself and others had the opportunity to make a fundamental curriculum reform, because it emphasizes the need to make your training of your future professionals, to make it socially accountable and to have an orientation towards the community. And for instance, Lynn Rijnstaart, who is in the audience also, coordinates actually the community-oriented primary care project experience, where students in the second year from different disciplines go to a community, contact people that live in difficult conditions, make a community diagnosis with the local healthcare providers involved, and look for solutions. So this kind of approach is already part of the program, and it has been always a part of the program in Africa. For instance, in Makerere University, where there was a very active program that the students at the third year went to the training places in family medicine practices.
Thank you very much for the answer. Another answer is from Erimina Marandu. I will just read the full message. Thank you very much for this insightful presentation and efforts to strengthen the primary healthcare in Africa. I'm a medical doctor working in primary healthcare in Tanzania. I would like to acknowledge the observation that more emphasis is placed on vertical programs as compared to horizontal programs. Are there any strategies in place to address this challenge?
Yes, it has been, I think, a major concern from the very beginning. Because, and that's just an anecdote, and I will not name the country. So what we experienced, for instance, was in a certain university, there was a training program established for postgraduate training in family medicine. And there was a huge building there built in front of the hospital. So I went to that building and I asked, would it be possible that every week when our students come together or trainees come together, that they can use a little room in this building to have their meetings? The answer was, and it was a USAID sponsored project, that is impossible because you are not working on AIDS. So this gives you a concrete illustration what verticalism means, and so we absolutely need to go for this horizontal integration. And of course, there is nowadays, and also if you read our article in the WHO bulletin, we say you have to kind of integrate vertical with horizontal. And then some people like Ohms call this diagonal, and I think this can work. That's why exactly we made a plea to channel 30% of the vertical disease-oriented programs to the strengthening of the local primary health care, and to also create win-wins. And if you do that, a lot is possible. There are excellent examples in Ethiopia where vertical programs have contributed also to capacity building and even to strengthen services in primary care. But for doing that, you have to rethink fundamentally the way you look at health problems, not in a verticalized way, but in a quite horizontal, transversal way. And I think that that's absolutely something we have to emphasize. And very often we see that also there, family medicine being a transversal discipline has it very difficult to get its place when you look at family medicine, very horizontal and transversal program, but to have its place next to all these vertical approaches and disease-oriented approaches.
Thank you very much. Mr. Oliver van Hekke, would you prefer me to read the question, or would you like to address it directly?
I can do it, that's fine.
No.
It's a question for Jan. I'm just going to read it out. Essentially, I mean, one of the challenges that I found is that the funders, particularly from the north, let's say in Belgium, want sort of most of the monies to actually fund sort of researchers from Belgium to actually go to Africa, for example, rather than actually using that money to actually fund local researchers, actually build research capacity, so that it's a split that it's actually so essentially so unequal, essentially. And my question, and with your experience, is that can anything be done about that, where we are actually not building in sort of research inequity in the sort of funding strategy?
Yeah, you are absolutely right. And it's absolutely a big concern. And I think that one of the things, the spin-offs of Primafamed, is that this discussion has started, but we are only in the beginning, and people still go the traditional way, thinking that we are going to do research in Africa, and then the Africans can help to collect some data, and then we will put them in the acknowledgement or as one of the authors down the row. At the end of the number 8 and number 9 is an African. I think this is a huge problem. And I think we have absolutely, if we want development and take it seriously, we have to make money available for research in Africa. And it should be quality research. I have nothing against competition for quality. I have nothing against the fact that you have to go for standards. That's not a problem. And they are all met in Africa, and sometimes better than in some Western countries, I can say, because the resources are so limited. So the choices are very have to be very well motivated. But I think we should absolutely go that way if we take it seriously. We recently posted on our website, 30 by 2030, a dramatic article written by professors in Botswana, who reported on what the MAPI project, the big project with the USAID money for Africa to develop medical education, what it concretely meant. And what it concretely meant was that they had no opportunities to develop, but that the US university, I will not know the university, I will not say which university it was, absolutely took all the resources and used it for their own careers of their own researchers in the north. Now, if you read that, your blood pressure will rise very high. This is absolutely in 2023. It's no more acceptable. Maybe we should have a kind of international mechanism, a little bit to look at the ethical dimensions of this kind of research, because we often do the same that with this, what we did since the 19th century, that's taking the resources out of Africa, but no return to the Africans and no capacity building to the Africans. We did it with the resources like lithium and all the rest, and gold and uranium and so on. And we do it now with the brains, and I think that's absolutely unacceptable. And Primafamed, I think, is the clear illustration. Go to the website and look at the journal, what the potential is of the African researchers, and of course, Primafamed, the journal, the African journal, is for many researchers the first step up to start a career. And we lowered the threshold for African researchers, and that gave a boost to the development of capacity. And I'm absolutely impressed, if I am in the jury of a PhD thesis, what the level and is of this, and also the scope of and the depth of the reflection that those students, PhD students, bring at their graduation into the presentation of their scientific work.
Thank you very much, Professor. I would like to give the floor to Willem van de Put. He shared an article on diagonal approaches being the answer to vertical versus horizontal approach. And then he also raised a question or shared insights on the problem of fragmentation. If you don't mind, Mr. van de Put.
Yeah, thank you very much. It's not really a question, it's more a comment. And I would like to, well, thank you for the insights, because we see exactly the same problem where in Tet province in the north of Mozambique, it's almost impossible to get work done on integrated primary care. And at the same time, whenever something small happens, there are delegations from organizations that we shall not name who come for specific disease-oriented reasons with lots of money for a problem that is not the biggest problem of the province at all. So I was just mentioning Gorik Ohm's article because I still think it's an interesting approach to try to maneuver between those two different, the horizontal and the vertical. And it's all been said. Basically, we know how to do it, but it's not happening. The donors are not following. So I hope that some donors are listening. Thank you very much.
I completely agree. We work together with Professor Ohms, of course, and I know the situation in Mozambique. I can only say, yes, this is absolutely a difficult area to work in, and people start with projects that are absolutely not contextualized and not start from assessing the needs of the population and mainly also involving the population, because I think also when we formulate research questions, you have to do that not only with the local researcher, but also involve the local population in order to make it relevant for the region. So yes, I agree. And the story of development of family medicine in Mozambique is a very sad story, because at a certain moment in time there was a very positive bottom-up dynamic, but then a minister had forbidden no more training, no more investment in training of family physicians. And fortunately, there was the UKZN, University of KwaZulu-Natal in Durban, that had a twinning with Mozambique, and so they could still give some support, but the situation was absolutely very, very difficult at that moment.
Yeah, thank you. If I may add one more thing, there is a perverse incentive also, because if we would like the people that we collaborate with from the provincial health authorities, if they would do what we think is the best thing to do, they would basically be stealing from their own wallet. It's the money that is paid by the international donors for them to do this makes it almost impossible for them as individuals to do it in a different way. And that is, I feel embarrassed in that sense to be part of the international global health work.
Fully agree. Thank you for this.
Yes, thank you indeed. Can I give the floor to my colleague, Peter? He also had a question on how to link your experience with other Fleer funded programs.
Thank you. Well, first of all, yes, I've already written it in the chat. I remember a part of the history of Primafamed since many years, so congratulations for all the work done on behalf of the African and Flemish promoters and collaborators. I was wondering, there are also some projects dealing with primary healthcare, and I'm not sure to what extent they are linked or not linked, whether they are also these collaborating centers, but I'm just referring to some initiatives that in Ecuador with Cuenca University, with UTPL, where we had some projects funded that were partially linked, I thought, with the topic, not with the Primafamed as such. And then in recently also, well, we're finalizing a long-term cooperation in Hue, where there is also a very successful project on primary healthcare with big impact on the national health system. So I was wondering how it links up, and how do you collaborate between African and international institutions? Maybe you mentioned some elements. If that was the case, then sorry, then I didn't grasp it.
So the question is Primafamed only an African story? It isn't. I'm sure that in Africa we have links with all the people that work on primary care development, except in the Western African part, the French-speaking part. We are now with Benin and with Togo working, and also we had some cooperation in the EU FP7 project with Mali, but that's ongoing. But I think we go into the right direction. Also, the African Journal publishes French translations of articles also. So, but that's still to be discovered and to be worked with because there are very interesting things happening in Western Africa. So, but when you talk about Latin America, Yes, we have, and I've been in Cuenca with the family medicine department. There's also been other projects from Ghent with Professor Lea Maas and others. Peter de Cat has been involved also. And Peter is also from the department at Ghent University of Family Medicine, recently was involved in the projects in Cochabamba. Since 1997, we had students from Ghent that went to Cochabamba, and we have been helping Cochabamba to start the family medicine training program in the late 90s and already early in this century. It was a very, very difficult enterprise, very politically influenced. But just 2 weeks ago, Christine Leens made a wonderful presentation of the work she did in the last 10 years at the defense of her PhD at Ghent University on her work she did in the last 10 years. That really shows how important international cooperation is and how universally acceptable and universally valid the concepts of primary healthcare are as a whole of society strategy, but of course how contextual the implementation should be. And it's always this kind of things, how to find appropriate contextual implementation. But her PhD work is absolutely very clear. I think that also with Uwe, Professor Anselm de Rees, who was also involved in the start of Primafamed and did a lot of work in the Urban Declaration later on. He was one of the promoters of the project together with Professor Martin Valk and others of the project in Uwe that led to the establishment of a stronger discipline of primary healthcare. Also there are a lot of structural challenges to give space to primary healthcare, as you know very well. But yeah, I think at least Vlier has the potential capacity to even be instrumental in a kind of broader worldwide Primafamed movement, because Vlier financed a lot of the project, and that's also why actually the project of Bianca is so important. We want also to have WHO on board. As you know, we recently have been celebrating the 45th anniversary of the Alma-Ata Declaration, 1978, on primary healthcare. And it's very clear now that they were going to publish now a new primer on primary healthcare. So there is renewed interest in WHO, not only in Geneva, but also in Brazzaville and other regions, to take it seriously. And I think there win-win situations can be created. And of course, WHO collaborating centers are always a kind of step up for instance, trying to have more credibility, what also can open doors for funding and so on.
Thank you.
Yeah, thank you, Professor. And maybe to stay on this topic, Peter de Cat has a question related on how to organize this mutual exchange. Mr. Peter de Cat? Or otherwise, I might read the question. So the question is, as a family physician, I fully agree that we in Europe can learn a lot from the African experience. Family physicians in Africa are doing different tasks compared to family physicians in Belgium. However, I think that the experience from Africa can be useful for tackling current health system problems in the European context. How could we organize this mutual exchange? Shouldn't we look for proposals that stress more this bi-directional exchange? Is there interest from funding organizations to finance this kind of experience? I guess this is also a question for us, but I'll give you the floor first.
Yes, of course, I fully agree with Peter's analysis, and that's exactly what we try to put into practice with the South-South-North cooperation. And it's in that order. It's South-South, that's the basis. But of course, there can be a North component, and just to learn a lot from each other. I think that this is absolutely that has been the DNA of Vlier from Primafamed from the very beginning, and Vlier has supported us a lot to make that happen. But I think you, at certain moment in time, you need a kind of basic infrastructure, like to keep such a network ongoing. And actually, that's one of the problems. We don't know in 2 years if Primafamed will still be active. We will do our best. But in ancient times, when you had a project, you could set aside some money for funding your coordination, your cooperation, your interaction, and your networking. Nowadays, that's no more possible. The mechanisms are strict, and there's nothing wrong with that. And there is no financing just for making this kind of sustainable networks continuing. And so on the daily basis, the Africans themselves have enough projects and ways to find resources, and it goes better and better for their research. But also there is no money for this kind of network infrastructure, and there's not a lot needed. But yeah, one of the things I'm pretty sure of, and that's not because I don't want to be to claim that we have any important role, but Primafamed network has been built based on personal relationships. And a recent visit 2 weeks ago from some of the people in the audience can illustrate that. People refer to this as a very important factor. And if that disappears, you cannot rebuild that, because it took 25 years to build that and to create a trust. One of the basic things, although countries are different, is that there is so much trust between different people, but that is stronger very often than political conflicts that in the region also happen by time and while. So I think that this is very important, and it's something typical for the Primafamed network also. And to maintain that, that needs a minimal financing, but it's so hard to get it. The last 5 years, it has been almost impossible to find the resources, and we use different strategies to try to obtain that. And of course, it's a pity because Vleer invested so much in all these projects. So it's a kind of harvesting on your investment if you can continue to create these opportunities that have this high developmental impact. So let's look for that to make it sustainable. So that's also my request to Peter Delannoy and others to find something. We had the IUC mechanism for institutions. I think it worked well. I'm a little bit in doubt nowadays if it is still so impactful as it has been. So maybe we have to look for other formulas, and this kind of networks maybe are worldwide to look at. Another limitation is that Belgian money can only go to a limited number of countries, which also is a problem. So there are a lot of bottlenecks that we have created that maybe we should rethink, because the problems are global, the world is global, and the solutions are global. And I think that does not fit with political priorities from specific countries when it comes to donor programs.
Thank you for that concluding insight. I'm afraid we're at the end of this presentation. But we would like to thank you all for attending this community talks. Thank you for your attention, your participation. We believe it's very valuable to have direct exchange with the experts and to share experience and insights. So thank you for that. And of course, special thanks to the speakers, Professor Jan de Mazeneer and PhD researcher Bianca Silva, for this insightful and inspiring presentation and discussion. So this community talk was recorded. We will share the recording on our YouTube channel and on our website. And we would also already like to welcome you for the next community talk that will take place on January 24th. And there we'll cover a research project on alternative approaches for integrated groundwater management in Bolivia. Very different topic, but also very interesting, I'm sure. Finally, allow me to use this occasion to wish you all a wonderful Christmas period and a Happy New Year on behalf of Vleer EOS. We hope to see you all soon next year. Take care. Bye.